So we are live in 5, 4, 3, 2, 1. We are live now.
Respected faculty and dear friends, welcome to the Trauma Symposium of this evening from Uttaranchal Orthopaedic Association. We are having weekly symposiums on every Thursday on different topics and different faculties. Today we have shifted to Saturday to let all our friends enjoy Shri Krishna Janmashtami. Friends, let me introduce our faculty and panelists to you. It is my proud privilege to say that they all belong to my alma mater, MLB Medical College, Jhansi. Some of them are my seniors and some are my juniors. And I have the privilege to work with all of them and learn from them. Our first speaker is Dr. Niraj Jain from Jhansi. He is an innovative trauma surgeon and a deep analyzer. Today he will be speaking on percutaneous fixation of radius head. Welcome, Dr. Neeraj. Our second speaker is Dr. S.K. Kaushik. He is professor at SRM Medical College, Bareilly. Besides being a good teacher, loved by his students and fellow faculty alike, he will be speaking on perfect execution of PFN in hip fractures. Welcome, Dr. Kaushik.
Thank you, sir.
I would like to welcome my senior panelist, Dr. Rakesh Sharma, who is trauma consultant at Kailash Hospital, Noida, and a person loved by his seniors and juniors alike. Dr. Sharma, sir, welcome you.
Thank you.
I would like to introduce our second panelist, who must be joining us just now. Let me admit them. I would like to introduce Dr. Neeraj Garg, senior ortho surgeon from Meerut. A hard-working, meritorious, and ever smiling face. I welcome you, sir. And I welcome third panelist, Dr. Madan Mohan Nagar. He is professor and head at the Rohilkhand Medical College, Bareilly. Besides orthopedics, he is a classical singer at par and a very learned personality in religious matters also. Dr. Nagar, sir, are you able to hear me? Dr. Nagar, sir, namaskar. He has not yet joined his audio, so we will again introduce him. And our last panelist, but not the least, is our own Dr. Girish Dang from Saharanpur. He is the president of his club for long, and he has been vice president of UP Orthopaedic Association. He is a trauma surgeon from Saharanpur. Welcome, Dr. Dang. And
thank you.
Today we have a very special guest panelist, Dr. Govind Sethi from United Kingdom. He is also joining us. Dr. Sethi is trauma as well as orthoplasty surgeon, and he has been our panelist and speaker in many symposiums of Uttaranchal Orthopaedic Association. Welcome, Dr. Sethi. Welcome. There is something. Is there any technical problem joining? I think Dr. Nagar has joined from two sets. Thank you, Dr. Nagar. So I would now request Dr. Neeraj Jain to please share his screen and start his presentation. Dr. Nagar, Dr. Neeraj Jain, sir.
Is my screen is visible to you? Everyone?
Yes.
But it's not full screen.
Yeah, I will start with first.
It's not full screen, Dr. Neeraj.
Okay.
Now it's fine. Yeah.
Okay.
Yes.
So, first of all, I extend my special thanks to Uttaranchal Orthopaedic Association for giving me opportunity to share my ideas with along with the fellow alumni of MLB Medical College. My regard to everyone. Thanks, Dr. Sirohi, for your generous introduction. I do not probably deserve such things, such a nice word. Still, thank you very much, Dr. Sirohi. Basically, my today's presentation is a bit different type of presentation. And it is actually a journey that how a good and simple idea, and if we work on that idea, we can improve it and give better and better dividends. So I'm starting that just a minute. It is actually some problem. Just wait a minute. Try to change it. Oh. Some problem. I think I will take a minute only.
Go to the slideshow.
I'm gone to the, just I will again sharing the screen.
Yes.
Just yeah. It is my story of a good idea evolving into a better idea. So this idea started around 2003, and I shared this idea in the POSICON 2004 held in Allahabad, where I presented this case, and we can see this man, K. Wilkins. He is a father figure in pediatric orthopedics, and he was there in that POSICON, and I was privileged to share this particular idea in form of a case presentation in POSICON 2014, and I presented there a case. So a long time back, but still it is interesting to share with you that this was the case. Date is X-ray is 2007, but actually it was around 2003 when we have did the case. Picture was taken in 2007 of the X-ray. So this was the case, the pediatric Montegia fracture dislocation, and beside the displaced ulnar fracture, there was a total displacement of the head. You can see on the upper picture the position of the head of the radius along with the this thing, and this was the AP view. So it is grossly displaced. Apparently, there was no connection between the head fragment as well as the shared fracture fragment of the radius. Obviously, radius Allah was also displaced. So when this case came to you, I was quite puzzled and hard what to do, because the earlier options which were available in the text is by open reduction and fixation by oblique wires. I was afraid to do this fixation because it was a bit of a problem to execute this type of fixation, as well as there are obstruction in the movement while wire was projecting out or inside the skin, but I was not liking it. Second option was transcapital fixation. This option was also scary to me because there are complications reported of the breakage of the wire, and then it is almost impossible to remove the wire, and moreover, whatever wire remain inside, then that may hurt the articular cartilage. So I thought, and then a new idea came to my mind, which I have not read anywhere at that time. So I rejected both the idea, and then another idea came to my mind. And this idea was, I will explain it in later, when as a result of this, I did the open reduction, and beside fixing this particular neck with the oblique wire or by this transcapital fixation, I started and introduced a K wire from the distal radial epiphysis. Here you can see the entry point, and then negotiated it proximally and reduced the head radius part. Here in this particular case, as this was grossly displaced, I have to open it and gently reduce it, and then go proximally and fix this epiphysis by this particular K wire, and kept it just proximal to the elbow joint. And this particular on the distal part K wire was remained outside. And after say 4 weeks, I removed this wire, and ultimately I also removed this rush pin, which was used for the ulnar fracture. This was reduced, closed. Then this was at the perioperative picture. At that time, we used the thermal printer to take the picture with the C-arm. And this was the follow-up X-ray after the removal of the K-wire. Patient had a very good result. So then when I shared this thing to the POSICON, faculty and every members was like this idea. I came back, and then I started thinking, can I do it better way? So then after some time came another case. This is 15 years old, 6 to 7 days old fracture, and this is with the gross angulation. So then obviously what we do now is we try to do the close reduction and try to reduce it. But at the 5 days after injury, it is very difficult, because in pediatric patients, neck fracture, they become very sticky in 5 days time only, and it is unacceptable position. So I again come to the another idea, that the idea is for the reduction of this type of angulation. Secondly, I thought, why to sacrifice the distal epiphysis? So I changed my entry point of this K wire, which was used to fix the reduced epiphysis. Entry point was changed to the radial sternoid to the just proximal to the distal radial epiphysis, so that I can spare at least one epiphysis. So this was the initial preoperative X-ray. This was after reduction and fixation. You can see now angulation is totally corrected. K-wire was there, and this was the final picture. This was the movement. Let me share how I reduced this particular picture. This was the follow-up after complete union. So now this was the detailed operative steps. So entry point I have changed from radial sternoid to just proximal to the distal radial epiphysis. This is the entry point made by a 2 mm K-wire. You can see it is sharp. Then after making the entry point, I change this K-wire and I take the K-wire which is relatively by cutting a tip of it and slightly bending it like this one, and introduce with the mounting over the T-handle, introducing it till it reaches just proximal to the fracture. Now we have to reduce it. So for this, I use another K-wire used as a joystick, and in the C-arm, I see the maximum deformity position. So this was the maximum angulation. I introduce it into the fracture, and this is, you can see the angle. Then I straighten it and reduce it like this one. Now this reduction has been achieved, and then I introduce this particular first K-wire little bit more till it is just proximal to the elbow joint. I do not violate the elbow joint. So this was the position. So K-wire is just proximal to it. Distally, this K-wire is left outside the skin, and for about 4 weeks. So this was another case. The same thing. It is in the side. So the maximum deformity point is here. So it is, you can see from this position, so it has gone just parallel to the shaft of the proximal radius. The same technique I have applied with the same success. So by this time, I have did many cases. So I thought, why not to share it? So in 2017, I published an article along with Dr. Anurag Kuchest, teacher from our MLB Medical College. We published it in 2017, Journal of Orthopaedic Association of UP, as a original article with the topic of treatment of displaced fracture of the radialness in children by closed reduction using K-wire and percutaneous intramedullary pinning. Now, can we do things still better? So then came this another case of adult neck radius fracture, which was similar to the same as we saw in a 15-year-old child. But in adult, what is usual practice? This is Kumari S, 23 years female, which fell and had an injury one day back, came to me, and this was the X-ray. So now I will request the audience, panelists to give their opinion or what they would like to do in such type of cases. That is 23 years female adult with this type of fracture. So any suggestion from any faculty or panelist? What they will like to do if this patient came to you?
Now that we know that you have a better option, I think we'll go with you. I have done fracture fixations with your technique at Noida as well. So I'm really happy about it.
So with this
I think
adult,
Dr. Neeraj,
yeah,
I think you are left out only with the three things, either the close reduction, and if the fracture is stable after the reduction, you can go for the conservative treatment. Or second is your option, it's a very good option. And third in otherwise the ORIF and with the fixation of the T plates. Probably I have seen the results with the wiring done by you like this. They are better than the T plate, T small plate. So definitely I am hopeful you would have gone by the same technique.
yes.
Because
So
that looks to be very nice in your hand.
Thank you, sir. So the option in adult are, as Dr. Neeraj Garg said very rightly, ORIF with T plate. But with the T plate, there are some issues, because if it does not unite, then failure of implant and failure of reductions is there. And moreover, stiffness chances are still there. So this is definitely an option, and it is a well accepted option, and mostly people doing T plate in this type of fractures. Secondly, the people do open reduction, and if it is oblique fracture with one or two interfragmentary screw. But this is quite a demanding surgery. It looks very simple that reduce it openly and then do the interfrag fixation. But I've come across in few cases where actually they end up with the combination of the fracture while applying the interfrag screw. Again, there is a issue of the implant at some places. And then open reduction and K-wire also some people do. A demanding surgery, but still an option. Then there is a, if patient is say lot of combination of the head fracture, then again it is not possible to reconstruct it. Then the displacement is there in head fracture especially. But replacement is still not completely solved solution. There are some issues of overstuffing and understuffing and the displacement. There are some issues with this replacement. And excision is, we always did it for completed fracture, still doing it, but usually it is at right now it is not a justifiable solution. Either we have to reconstruct or we have to replace the head part of the radius. So I think these are the options which we have discussed it. And I tried it in this particular case is the same view. This is the same thing. That is the entry from the distal part of the radius. Here there is no issue of the epiphysis. So I started with the radial stenoid, same way. Exactly same way. This is the curved part and the blunt part of the tip of the K-wire, which has been kept blunt so that we cannot prevent it. We prevent to penetrate it from the joint, because if it is sharp, then it may penetrate the articular surface. And then same thing, the joystick, and did the reduction. And then we advance this K-wire just proximal to the elbow joint. So this was the position for operative, and this was the post-operative. A little bit translation is there, but I accepted this. This is the same patient 3 weeks post-op, and this is 5 weeks, and subsequently I have removed it. This is at the 5 week, there is function. So this was the movement, and this is 7 week after the removal of K-wire. Fracture is in process of union. I have not waited much and removed this K-wire, and it has started mobilizing it. Patient has fantastic results in adults also. So we had now another solution for this type of fracture, which is not that uncommon. So this was the, now this come another lady. This is Kumari A, 23 female. She is a lawyer by her profession. And this came to this fracture. Again, similar type of fracture. And I put here the difference we made in adult, that you do not keep K-wire outside the skin, because we have to keep a bit more time. But problem is, another problem came with this thing. If we keep this wire inside the skin, patient may not come for the removal, but doesn't make any difference if patient is all right with wire in. So this is around 1 year back I did this surgery, and this was the peroperative pictures. This was the postoperative picture. You can see the wire well inside the skin. And this is at the joint level, perfect reduction. She did not turn because there was no stitches. So neither she, even for the distal part of the K-wire introduction, there was no stitches, because I just cut and bent it and buried it inside and pulled the skin. So there was no incision at all. She did not turn up. I called her 2 days back and requested to send the picture. The patient gave the picture herself, this type of slide. And so this was the function right now. So she's saying that she's perfectly all right, doing some job in the Delhi, and very happy. So this is how we go for this technique, extended this technique in the adults also. And I found that this particular technique very, very useful in adult neck radius fracture also. So in conclusion, we can say that there are different options for the neck radius fracture, but our method is simple, safe, and provide adequate stability. So I conclude that acting on a good idea is a better thing than just having a good idea. If we work on it, we can improve it on idea and come to the better and better position. Here are the various references. So I thank everybody. And now I think if any question or any queries from the panelists, from the audience, if at all there, I'm happy to answer it.
Yeah, Neeraj.
Hi,
Neeraj,
Dr.
can you hear me?
Neeraj. Hi, sorry.
It's Seti. Can you hear me?
Yeah, Dr. Seti, I can hear you. Hello.
All right. Okay. Yeah. I think let somebody go first. I'll come back later. Okay. I think I'm not on the queue. Let somebody ask the question first. I'll come to you.
Okay.
Dr. Neeraj, I have a question. What size of K-wire do you use usually?
Usually, almost always I use 2 mm K-wire.
2 mm.
Thicker the K-wire, in children it is not required. In adults, mostly 2 mm is sufficient. The reason of the 2 mm K-wire is maneuvering this K-wire is easy. Then it is not like this. My aim is not a rigid type of fixation. It is just like an umbrella, that this wire is going up and making it the same level. And there are certain amount of correction at times I see in the post-operative period also. Slight 1 mm here and there. and there is no need of rigid fixation with the movement by two opposing surface. They glue very well the fracture, and in worst come worst, if they are in adult, especially in children, there is no chance of not uniting it, but in adults there may be some chance that it may go into the fibrous union or maybe non-union. Then it will work as a good spacer, just like
In any case, it is hinged
yeah.
between condyle and
yes.
radial.
So 2 mm is enough, because they are very rigid, actually 2.5.
Have you ever used a tense nail? Because I have used tense 2.5 mm
Yes, sir.
quite a
Yes,
few times, and I was happy with the results. Because
Yeah.
negotiating a tense into the radial canal is easier than negotiating a K-wire.
Yes, sir.
So I found it a good alternative and had a very good, because when you hammer the tense, it also goes and penetrates into the radial head and fixes it well.
Yes, sir.
Do you have
Sir,
any experience with tense nail?
Sir, actually, I have not used tense nail, but I have discussed, as you said, that many of our colleagues are using tense nail. So it is a equally good thing. Tense is because I have blent the tip of the K-wire, so actually it is working like
You
same
practically make it as a
and
tense case.
same thing, and tense is definitely better. But as I'm using this, and I have access of the 12-inch and 9-inch K-wires. Usually, actually, 9-inch and 12-inch K-wire is not that easily available, because I'm using it from so long. So I have got access of all the thickness, and I have got 1.8 to all these K-wire with the 12-inch size also. So otherwise, whatever is available, it's quite good. The tense is much easier to get than the 12-inch K-wire.
Yeah.
Because in adult, you have to have 12-inch K-wire. And 9-inch K-wire is usually short.
You were asking something?
Dr. Neeraj,
Yes, sir.
can I ask?
Yes, sir.
Dr. Neeraj, it's a really very good presentation. And technically, we see that that fixation is only by a single point fixation.
Yes, sir.
Yeah. So, and that to a very small segment. So, any sort of immobilization do you prefer? Number one. Number two, how do you decide the rotation of the fragment, or for the supination and the pronation, that the fragment has completely in the anatomical position? And third, when do you remove this wire to secure that the complete union has been there? And fourth, what is the incidence of non-union?
First thing, the rotation part.
Yeah.
What I do is, as I said, this is a single point fixation. In one or two cases, operatively, I have tried to K-wire initially to see whether how it works. So they did not work well, so I removed that and there. So about the rotation, what I do is I put the K-wire in place, and I do the pronation and supination quickly few times, and hoping that by this natural movement, full rotation and supination operatively, whatever malrotation position is there, it gets corrected when there is a transverse fracture, especially in adults. In children, there is not of much problem. They usually follow the periosteum, which is along with the proximal fragment, and it is type 2 fracture. Then it is visible in the X-ray that in image intensifier that this came into the position. So this is the only procedure. Otherwise, if it is not a, say, if it is transverse fracture in adults, then there is no way we can confirm that this particular rotation part is done, frankly speaking. So I just hope and presume that by doing the rotation movement after the reduction, whatever small correction is possible, I do it before putting the final position of the K-wire and after putting also. So per operative, I can see there is some change of the position of the bone, and I presume that it is for better. This is the one part. In children, there is no problem because there is a thick brainstem. Whenever it reduces, it is always anatomical reduction. Means there is no chance of the rotation between the mild rotation between the proximal and distal. In adult, definitely there is chance. Secondly, second question, sir, your about the when I remove it and the union in children. As I keep this wire outside the skin, I reduce quite early. You can say 4 weeks is the upper limit. Regarding immobilization, maximum 3 weeks, I keep the slab, and I do not find any restriction of the movement because of this immobilization. In adult, I usually keep wire for a longer period because union took place for quite some time, and it at very few occasions it is radiologically I do not see union in adult cases. So there are some incidences, but as I can say, it is not a very long series in adults. So in one particular case, I remember that there was no union till I followed up the case, but result-wise, it was perfectly all right. So it was probably used as a spacer. And in adults, I removed the K-wire after I definitely see there is a good amount of union. But as I said earlier, the wires are in, and at times patient did not turn up because I have this particular last case which I have shown. I've called the patient a few times, and his father and always saying that Dr. Sahab, hum kahan rahe hain, hum nikalwayenge taar, but they did not turn up. But कोई problem नहीं है, चल रहा है, so just like that. And any other nail which is not hurting the patient, they avoid the surgery at times, but there is no harm per se. And either, sir, I think this asked 4 things. I have asked 3 of them probably.
Yes, Dr. Dang.
Yes, I would like to say that Dr. Neeraj, yours was a very nice presentation and very good presentation, and your method is more biological.
Yes, sir.
Especially in children. So in children, it's very good. But my query was in adults. वो ये सवाल मेरे दिमाग में भी आया था कि कितनी देर रखते हैं आप वायर को एडल्ट्स में, और उसके बाद कोई मतलब इमोबिलाइजेशन करते हैं कि नहीं करते हैं, करते हैं तो कितनी देर करते हैं, तो उसमें कोई आपका कोई मीन पीरियड है कि भाई 40 दिन रखनी है या 30 दिन रखना है या कितना रखना है? अच्छा, फिर उसमें एडल्ट्स में मान लीजिए कोई ओल्ड है, मान लीजिए अबाउट 60 है, मान लीजिए अबाउट 45-50 है, उसमें क्या करते हैं? पहली बात। दूसरी बात ये है कि कोई कम्युनिकेट फ्रैक्चर है तो उसमें कैसे होगा? उसमें तो हो नहीं पाएगा, या उसमें भी आपने कभी कम्युनिकेट में ट्राई किया है? किया है तो उसके क्या रिजल्ट रहे आपके?
Communicated means the head part has to be intact. Head part has to be intact. Head part has to be intact.
नहीं मतलब उसमें तो फिर या तो
उसमें नहीं कर सकते सर,
रिप्लेसमेंट है या और इफ है, मतलब अगर मैं एडल्ट्स की बात कर रहा हूं।
यस यस,
मेरा क्वेश्चन
आई एम टॉकिंग ऑफ एडल्ट्स।
आपका जैसे आपने एडल्ट में आपने वायर डाल रखी है, तो आपने कहा कि वो स्किन के नीचे है, एक्सपोज नहीं है, ओके?
यस सर।
तो आप उसको कितनी देर कितने दिन उसको आप इन सीटू रखते हैं और कितने दिन के बाद निकालते हैं? आपने कहा यूनियन के बाद, आपका मेन यूनियन पीरियड क्या है?
Sir, usually I start seeing union in adult also, say in 8 weeks time. It's not like this complete union. When I'm seeing the union, usually my idea is remove the wire 2 month, 2.5 months, not later than that. Because if it is not uniting after 3 months, probably it will not unite later on. So then I will presume that this head will be work as a spacer. So I don't bother about the union and just take out the wire.
Just a minute.
Yes, sir.
3 महीने तक आपने अगर वो वायर अंदर रखी है उसके,
Yes, sir.
और आपने कोई इमोबिलाइजेशन नहीं लगाया हुआ है ना?
Yes, sir, नहीं लगाया सर, एक महीने के बाद निकाल दिया.
कोई आपने प्लास्टर तो नहीं लगा रखा ना?
No, sir. Initial for 4 weeks plaster, then remove it and start mobilizing it. Not bothering for the union.
4 हफ्ते आपने प्लास्टर लगाया, उसके बाद मैं एडल्ट की बात कर रहा हूँ.
Yes, sir.
4 हफ्ते आपने प्लास्टर लगाया, उसके बाद आपने उसको मोबिलाइजेशन जो है अलाउ कर दिया.
Yes, sir.
और वो आपकी जो वायर है वो मतलब हेड में है, उसको उसने मतलब एंगेज कर रखा है. ओके.
Yes, sir. Yes, sir.
तो कभी ऐसा भी हुआ कि 4 हफ्ते के बाद वो जो है फिर से डिस्प्लेस हो गया?
नहीं सर, जो पोजीशन होती है that remains there, whatever if at all there is any change.
क्योंकि वो जैसे डॉक्टर ने कहा कि सिंगल पॉइंट वो है.
Yes, sir. Yes, sir. The advantage of mobilizing the elbow joint is that with the movement, the position, if at all it change for the better. That is what my observation is in this type of series. It is changed for better. It improves the position with the movement. Secondly, I do not bother much. Literature also support this about this union. When there is a biological, no open reduction and fixation is biological, it will work as a spacer. It unite or may not unite doesn't make any difference in the result in form of any movement. Movements are there is no pain, and patient, say even it is a 50 years or so, the method is always the same. As far till there is a one piece of the head. If head is completed, then I have to do the other technique. Then it is not possible to execute this technique when there is a combination of the head fracture.
Yes, I agree with Dr. Neeraj, because there is no point in immobilizing after 4 weeks. You will be inviting stiffness in elbow, and whether it is a calcified union or a fibrous union, it is sufficient to support the head.
Yes.
Another thing, I'd like to make a comment on the rotational or malrotational problem. See, in a transverse fracture of head radius, it's a smooth circular round thing and it is free of any soft tissues. So it hardly matters whether it is in a 12 o'clock position or in a 3 o'clock position. It will work as it does for rotation. So you can't judge it on a C-arm. If it's a short oblique, you can always judge and do the things for reduction. Otherwise, for a pure transverse, don't bother for any malrotation, because in any case, it will work as a circular body. So no point in being harassed by the exact rotation.
Yes.
You can't do it, and it's not needed as well.
Yeah, Neeraj.
No, I think Dr. Neeraj, the rotation in forearm is a very important issue.
Yes, sir.
So there must be some criteria to decide in adults whether it is completely perfectly, because in all the juxtaarticular and intra-articular fractures, basic principle nearer to the anatomy, as much and painless movements. So I think we must consider another aspect of the rotation, whether it's perfectly rotated or not. Otherwise, it will lead to the fibrous union and will be painful.
But judging rotation in a transverse fracture is very difficult on a C-arm.
Yes.
Though difficult, but we have to consider the perfect treatment.
But
No,
Even,
one thing,
sir,
we judge it.
if you look into the set here, I mean, I don't think rotation matters too much.
Hi, good evening, Dr. Sethi.
I think, sorry, I came up a bit late and problem with the hiccup, the computer, there's a problem. I don't think you can see me. The rotation is not a much of a problem in radial neck fractures. If you see
Yeah.
the implant replacement, they're circular heads, you know, there's no oblong, they're circular. Yeah, I don't think it matters too much. If you look into it, what happens when you excise the radial head, which you shouldn't be doing it, rotation don't get affected because the radial, it's an annular ligament, how it's placed.
Circular.
It's a circular. Important thing is, Neeraj, I missed the start of it. We do have this problem from time to time, and we tend to use, as Dr. Sharma was saying, you know, we used to use an elastic nail, which is something like TENS nail. What do you tell to your patient? You've done a very good presentation, excellent results. I congratulate you for that. But one thing one has to take for advantages, we should not be over jumping on doing these reductions. There is a caveat because some patients, there's a high risk of PIN injury and avascular necrosis. So the people who want to do it, make sure they don't go too distal to the neck. If you go too distal, you're going to do straight the PIN, and the PIN in 3 years, 4 years of age, it is a disaster waiting to happen. So there are the few things one must be keeping in mind. Also, last week I had a fracture, we don't always tell to fix it. If my angulation is around 30 to 40 degrees, if it was, you know, it was angulated, I manipulated, I came to 30, 40 degrees, I don't even fix it. But what you've done is good, there's nothing wrong in it. But at 30 degrees, 40 degrees, they are stable, and believe me, we don't immobilize any of our radial neck fractures in this country. Unless and until you have put some, as you did, a wire in which you need to put it for about 3 to 4 weeks. For normal neck of radius fracture, there is no need of any immobilization. Just a sling, and ask them to mobilize at 10 days time is good enough time. They get a better range of movement. So the message should not be taken lightly. This carries a complication of PIN injury when you're doing a joystick maneuver or doing, what you call as your K-wire. Avascular necrosis is also known in these patients, especially when they go right to the extremes. So two things have to be taken into account. Circular reduction, close reduction, rotation doesn't really matter much. As you rightly said, Neeraj, in the kids, there is a periosteum, which comes in the way. Sometimes you have to open it. In spite of doing everything, don't go too distal. It has to be very carefully looked into. I've seen patients having AVN and a PIN in cases like that. But very good talk, really good one. Well done.
Dr. Sethi, I must say that whatever you said that, yes, PIN injury is a very, very difficult proposition, and definitely there are chances of complication. It is a known complication of the nerve injury. AVN I have not come across. Probably AVN is more common when we go for the open reduction. Right, yeah. Fortunately, in children, I have not required open reduction in many cases, except in my first case. So that is the thing. So I have not come across the AVN. But yes, unfortunately, in my last case, last few months back, I had a patient which developed a PIN, and I'm hoping that it will recover. But definitely there is a risk, and it is very, very difficult problem. In adult, many years back, I had this problem, but that lady recovered well after 6-month period. But it is very weird complication, intraosseous nerve injury. And I did across in one case, in pediatric case, and that was the last case I did it.
Yeah.
So that was there. But there is a path of the K-wire which is described in Campbell. It is relatively safer path to reach at the fracture side and do the joystick.
I think that's
that
what
is mentioned in the Campbell. That is to avoid this nerve. And definitely, if you go too distal of the neck radius, the joystick, and manipulation is too much, then there are risk of the nerve injury. That is very true, and one should avoid, and one should know that there is a risk of the nerve injury while doing the joystick reduction. I agree
Dr.
with you, whatever
Neeraj,
you said. Yes, sir.
I would like to ask the joystick K-wire is a sharp one or it is a little blunt?
It depends, sir. To start it is a sharp one, but
No, no,
to
that one,
make
the
the entry
second.
point again, it is a sharp one, and then when I make the entry with the perforation, then I make it little bit blunt. Tip of
I'm asking of the second K-wire.
I'm asking, telling the same thing. Second K-wire.
Okay.
Okay. It is actually initially I'm using sharp one, then I found it that is difficult, then I put it a little bit blunt, and when try to do it, and it becomes work very nicely, this joystick.
Thank you, Dr. Neeraj.
Especially Neeraj, if you
Neeraj, am I audible?
Yeah.
Yes,
Am I
yes.
audible, Dr. Neeraj?
Yes, audible. Please, sir. You are audible.
Hello, am I audible?
Yes, sir.
Yes.
Yes. Dr. Neeraj, your presentation was very innovative and very nice. I appreciate it and congratulate you for this very nice presentation and the results you have shown. But there are two questions which remain unanswered. Dr. Neeraj asks, I presume
Please, sir.
that still requires clarification. Number one is, this is single point fixation. What about the stability? How you decide it and how much it is there? Number one. Number two, it is partially answered. What is the position of immobilization, both in child as well as children as well as in adults? Whether immobilization was done or not, and because there are two views, Dr. Sethi is not in favor of that, as I could get it. And what are your experience about these 2 points?
Yeah.
Stability and immobilization. Thank you.
Regarding stability, sir, we require or we aim a relative stability, not a rigid stability, and single point and single wire is by choice. Because as I said that we need only relative stability, and whatever, say, malrotation or whatever we have, say, missed at the time of surgery, post-operatively, even with the slab or after while we are mobilizing it, it improves, if at all, is there any change. It is always for the better. So there is no issue with the stability. Whatever stability we require, it gives by the single K-wire. I never advocate the 2 K-wire. I've tried during surgery in 1 or 2 cases, and I removed then and there the second wire. So it doesn't help. I tried it and I removed it at that time only at the time of surgery itself. So it doesn't help 2 wires. One thing. Secondly, the mobilization, maximum 4 weeks is enough. I'm not aiming for the much mobilization because this particular relative and small fixity stability is good enough for this result. Because even in the adult union, if that will unite, and those cases don't unite, they will not unite. So I'm not much worried. They will work as a spacer. And the most important point is the function. Function is always good. If it is a close, there's no issue of stability, stiffness, and not much issue. There may be some weakness of the grip or all that. And non-union is mostly in the later age group. So they're not required much. And as Dr. Sethi said, in many cases of this particular neck radius fracture, when the position is good, but there is a fracture in the X-ray, in acute case, I did not mobilize until unless patient says there is too much pain. I give no slab in acute cases if it's stable in adult when there is a very acceptable position And straight away I say, as your pain reduce, start mobilizing it in a week time, in 5 days time. And I never put the plaster, only a sling. And again, in this type of conservative management, result is always very good. Movement wise, it is excellent. Pain within 3-4 weeks, they becomes say all right. No plaster at all. So it is tempting to put a plaster, but it is definitely not needed.
I think
But you
have
must
to-
be
Dr.
instructing
Neeraj,
Thank
them
you. You
not to
explained it
give-
Dr.
very
Neeraj.
nicely.
Huh.
Yes,
Sorry.
sir.
Sorry, please.
Yes, doctor, you can continue.
No, you can go ahead.
He's explained very nicely in my way. Okay, that was the only question I was interested in. Now,
Yes.
Dr. Neeraj Garg, may please proceed.
Yeah. Dr. Neeraj, this is one of my query that how to decide that this is the fit case for the wiring on the basis of the plain X-ray, or routinely you go for the CT. So what's your protocol about it?
Sir, I have not gone for CT in any case. There is simply, when there is only neck radius fracture, no in adult, means there is nothing like dislocation or like this terrible triad or so. I straight away decide in the X-ray only. In neck radius, if it is unacceptable, I need to reduce it, then I go for the KY fixation. Otherwise, I did not do any fixation or any mobilization if their position is good in case of the adults. Same thing I go for in the children also. If I need to reduce it, and then I fix it.
Thank you, Dr. Neeraj. Very nicely explained for us.
Thank you.
So we end with this session, and I would now request Dr. Neeraj to please stop sharing the screen. Dr. Kaushik will be our second speaker, and he will be speaking about perfect execution of PFN in hip fractures. Dr. Kaushik, please share your screen and start your presentation.
Okay, sir, just a minute. Is it okay, sir?
Yes, it is there.
It is visible.
Okay, sir. Let me
go for full screen.
It's full screen on my side.
Okay.
Is it okay?
I think it's perfectly okay.
Okay.
Is okay
Yes,
for
sir.
everybody?
Yes.
It looks good. It looks good. Yeah. Go ahead.
First of all, let me pay my sincere regards to all my seniors whom I have been seeing in the medical college. And after a very long time, we are meeting, and that on the screen. It's a good opportunity for all of us. So I'll be discussing regarding the various steps of the proximal femoral nail in the interjoint fractures. First of all, we have to be careful in selecting the patient who is physically fit, because most of the patients are from the elderly age group. Sir, is it audible to everyone?
Yes.
Okay, sir, let me continue. So either it is a transverse fracture, reverse oblique fracture, subtrochanteric fracture, or proximal femur, any kind of fracture in the intertrochanteric area, we can try to fix by the proximal femoral nail. First of all, what is the position of the patient? Patient lying supine on the OT table with the other limb tied to the foot post and the limb which is fractured tied to the traction post. Having sufficient space in between so that our C-arm image intensifier can move easily to take the AP and lateral view of the hip area. So AP and lateral view must be including, first of all, we have a preoperative X-ray that should be having AP view, lateral view, and also we should have an X-ray of the pelvis itself, because we want to know the exact status of the bone whether it is an osteoporotic bone or normal density, any pre-existing deformity because of earlier fracture, what is the canal diameter, and what is the thickness of the cortex of the bone which we are going to fix. Any underlying local pathology like metastasis or severe osteoporosis we have to consider before we are planning for the fixation of the fracture. Like this, we must include the hip joint, the knee joint, and whole of the femur so that the whole bone is visible in the X-ray, and we remain careful while we are dealing with the various This gives us the information regarding the contralateral hip. What exactly the configuration of the other hip is, because it may vary in the different patients. So after having AP view and AP view of the hip in whole of the thigh with the knee joint, and the AP view of the pelvis with both hips, sometimes we may need traction view also, because after of the traction, the fragments may fall into the position, and we can have an idea regarding the various fracture fragments where they are lying. Otherwise, in AP view they are overlapping. So we should have a traction view sometimes when there is a combination of the fracture. So most of the time what we are using, either a DHS, earlier we are using a lot DHS in the intertrochanteric fractures, and now after the introduction of the proximal femoral nail, most of the time we are fixing the intertrochanteric fractures with the PFN. So what is the technique? Mainly, as we have discussed regarding the positioning of the patient on the table, table. So we should put the patient on the post of the side of injury, because that will help us in taking the AP and lateral view properly. Otherwise, there is an obstruction by the post plate. So for a better lateral and AP view, the hip or the side of injury should be posted on the side of the injury, because there are three posts, middle one, the left and right. So if you are operating upon the right side, we should shift the patient toward the right side. Both the feet and ankle should be well padded and very well tied to the post. Because when we apply the traction, many times what we have seen, the foot goes out of the foot piece. So it should be very well tied with the full padding. And do not forget to add a support near the chest wall. Otherwise, many times patient falls down at the time of the application of the traction. Our assistant is applying the traction and is increasing the traction, and suddenly patient falls down from the table. So we have to apply a side chest support. Like this one, we have posted the patient on the table. CM is also ready. Our instrument set is also ready. And one more thing, one should not apply too much traction. Otherwise, there are chances of the femoral nerve stretching. Our perineal post should be very well padded. Check the genitals to protect carefully, and very well padding around the genitals. Arm on the surgical side should be placed across the chest wall, and it should be fixed to the operation table by an adhesive tape. The torso, the trunk should be pushed to the opposite side to make our greater trochanter more prominent, so that we can access the site. Sometimes we may require these special instruments, because we face a problem in the proximal femoral fractures because of the special position of the proximal fragment. It is lying flexed, externally rotated, and abducted. And it's such a small fragment, it's very difficult to control this fragment. So sometimes we may need these special instruments like a ball spike pusher to help correct the varus of the proximal fragment. Cobb's elevator or Bristow elevator to manipulate the reduction when proximal fragment is lying in flexed or extended position. So we may keep it anteriorly or posteriorly to bring about the reduction. Either we may access it through the same incision. A little longer incision may be required sometimes, or we can make another small incision over the proximal fragment so that we can manipulate it at the time of reduction. Sometimes reduction clamps may be required if by our all the efforts we could not achieve the good reduction. We may have to go for the open reduction. In that condition, either we keep it fixed or temporarily fixed with the K-wires. After achieving the reduction, we may keep it fixed temporarily with the K-wires passed through the anterior cortex from the distal to the proximal fragment. Or we may keep the reduction clamp in position so that till we pass our guide wire, this fragment does not dislodge. So when we start the reduction, first of all, let us try for the close reduction by longitudinal reduction, even before the part preparation. First, beforehand, we should go for the close reduction under C-arm. Apply the traction, go for external rotation, followed by internal rotation. Most of the time, we can achieve the reduction if it is not an old fracture. If it is a fresh fracture, it's not very difficult to achieve the reduction, but sometimes because of the severe comminution, it is not so easy. So after having close reduction under C-arm before part preparation, let us see the tip of the greater trochanter is at the level of center of the femoral head. In exceptional cases, there are changes, but most of the time, the tip of the femoral head is lying at the center of the femoral, tip of the greater trochanter is lying at the level of center of the femoral head. So that is an evidence whether we have reduced the fracture up to the optimum or not. Like this one, this is a fracture of intertrochanteric area, AP and lateral view. Before part preparation under C-arm, we have reduced the fracture, very nicely reduced in the AP view as well as in the lateral view. Then our work has been completed at least 50%. If reduction remains stable and we are able to pass the guide wire, our 50% work has been done. Otherwise, most of the time we are putting ourselves into hassle. Reduction is not achieved and it is not stable. So that is the great problem. Just to assess whether it is in varus reduction or valgus reduction or an optimum reduction, see in the X-ray, I mean on the C-arm, if GT tip, greater trochanter tip, is lying above the level of center of the femoral head, it is the varus reduction. And if greater trochanter tip is lower than the center of the femoral head, it is the valgus reduction. So let us have a check whether we are going to have varus reduction or valgus reduction, or it is an optimum reduction. And ultimately, if close reduction could not be achieved, don't hesitate to go for the open reduction. Because many times we are dealing with this reduction again and again. We are doing AP and lateral view, AP and lateral view, and still we are not getting the right alignment so that we can pass the guide wire in the center. So in that condition, it's better go for the open reduction and fix it either with the help of two K-wires passed into the anterior cortex, or apply some reduction clamp so that till we pass our nail, this reduction remains stable. Insertion of guide pin. Many times we are doing a lot of hassle only with the passing of the guide pin. It is going anteriorly, it is going posteriorly, it is not in the center. So what to do? First of all, the guide pin may be inserted percutaneously. You just a pin prick is enough to reach to the site of your guide pin insertion site, and then we can extend the incision if we are at the right place, because that condition we are not going to have very large or a big incision. If we are entering at the correct point, just enlarge the incision proximally as well as somewhat distally, approximately 3 centimeter long is enough. For the correct entry of the guide pin in AP view, see the tip of the pin should not be having any overlapping with the bone. Just your pin should be at the tip. If there is an overlapping, when we are introducing the guide pin, if there is an overlap of the cortex and the bone, the cortex and the tip of the guide wire, it means it is either going anteriorly or it is going posteriorly. So we start when we just see that our tip of the guide wire is just touching to the bone, and there is no overlap of the shadows of the tip of the guide wire and the bone. It means you are in the center of the thickness of the bone. So if there is an overlapping, again try and go only when there is no overlapping of the tip and the bone shadow. Then you just dig the guide wire to just make it stable and check in the AP and lateral view both. And ultimately, if could not be achieved, then open reduction is the ultimate answer. Like this one, first we just keep our tip of the either trocar or the guide wire at the point of entry and check in the AP and lateral view both. If our entry point is okay, then this guide wire should be going centrally in the lateral view also. Or we can manipulate just a little bending at the tip of guide wire is fast. This bent tip of the guide wire helps a lot in changing our position, whether we are central or not. If we are towards anterior cortex or towards the posterior cortex, we just rotate the guide wire and dig it into the center. I would like to stress upon the lateral view, because many times in AP view it's beautiful, but when we go for the lateral view, again we are either towards near the anterior cortex or near the posterior cortex. That is not the right position. We have to go centrally in the lateral view. So again and again we need lateral view, but just target the issue in AP view and complete it in the lateral view. Similarly for the reduction and also for the insertion of our guide wire. So in the AP view, we are using different nails with the 5-degree angulation or 7-degree angulation, depending upon the nail, what we are using or what we are choosing. We have to make our entry just medial to the tip of the greater trochanter or at the tip of the greater trochanter, depending upon the nail. And it should be in the center of the medullary canal in the lateral. Okay, so this has to be manipulated with the bent tip of the guide wire. Now, once we have entered into the canal, let us go ahead. The guide pin should be introduced up to the level of lesser trochanter. Now, canal opening reamer, that is as wider as the diameter of the proximal part of the nail, that should be advanced at least up to the level of the lesser trochanter. So at least full length of the anterior part of this canal opening reamer wants to be passed, so that our nail lateral fits properly into this proximal part. Because otherwise, what will happen? If we have not opened the canal up to its full length, the proximal part of the nail will not be going or will not be advanced further, and we shall be in trouble. If we do it forcefully, we may shatter the proximal part of the femur again. So it will be very hard to pass if the canal has not been opened up to the desired diameter and up to the desired length, so that the proximal part of the nail very well fits into the canal of the proximal part. Now, guide pin and the canal opener is removed. And now we use a long guide wire that is inserted up to the level of distal femoral physeal scar. And to keep in mind, tip of the guide wire is digged into the cancellous bone of the distal femur so that it does not displace again. It does not change the position when we are putting the nail in. Keeping the wire in center in both AP and lateral view. Again, here lateral view is very important. Otherwise, what will happen? If wire is nearer to the anterior cortex and we are using a long PFN, that may shatter the distal part of the femur. So keeping the wire in center in both AP and lateral view is a must, and that can be done. Just again, the bent tip of the guide wire will help. Just to change the position, tip can be rotated and the desired position can be achieved. And the tip should always be digged into the cancellous part so that it does not displace again. Now, reaming can be done for the medullary cavity with the increasing diameter reamers up to the last reamer can go easily because we want a snugly fitting nail. It is neither touching to the anterior cortex nor to the lateral cortex. It should be snugly fitting into the canal to give the better results. And nail selected is always 1 to 1.5 millimeter less diameter than the last reamer we have used. Never use the same diameter nail as the last reamer has gone. Otherwise, it's very difficult to negotiate. Here you can open the canal up to the desired length with the help of this canal opening reamer. This I've shown here, the guide wire should be going up to the distal most part of the femur where you can dig it into the cancellous bone so that it does not displace, and when we are inserting the nail remains in the center. If we have left this guide wire proximal to the condylar portion, then when we are putting the nail, it will be going into either plane, not in the center. Either we are using the short nail. Many times, if we are using short nail, we don't need much reaming, we don't need a longer this guide wire. But when we are using this long PFN, this long guide wire is a must, and reaching up to the condylar portion where we can fix it into the cancellous bone. Another point to keep in mind: the drill sleeve, the drill guide, and the trocar should seat upon the lateral cortex perfectly while you are reaming for the leg screw and the derotation screw. If we have kept it little away, our trajectory is going to change. So our guide, drill guide, the drill sleeve, and the trocar should be perfectly touching to the lateral cortex, and then ream for the leg screw and the derotation screw. Reaming for the proper length is also must. First, ream for the leg screw or the compression screw with the 6.5 mm reamer, where we will be putting the 8 mm screw And for the upper one, the derotation screw with the 5 mm reamer, where we'll be putting the 6.4 mm screw. The guide wire, once passed, both the guide wires, we have to pass one after the other. Again, if short PFN is used, reaming may not be required many times, as we have discussed already. And one important thing, avoid using the hammer to insert the nail if a long PFN is used, particularly in the elderly patients, because many patients are having excessive bowing of the femur, and tip of the nail may perforate the anterior cortex. If we are using the hammer and you are applying much force, the anterior cortex may be perforated or even shattered with the force of the hammer. Distal interlocking screws may be inserted by freehand technique. The static locking is used for intertrochanteric fracture and dynamic locking for the subtrochanteric fracture. Here we have passed both the screws into the nail. Again, a very important thing to check. Both the guide wires in the neck should be almost overlapping in the lateral view. Only then we would be lying centrally in the lateral view, or both the screws will be lying one over the other. So shadows should overlap in the lateral view for the proper nailing. Otherwise, if they are not overlapping, it means they are not in the proper position. The tip of the compression screw should be left within 1 centimeter, within 10 mm or 1 centimeter from the periphery of the head of the femur. So take home message, first of all, proper patient selection is a must. We should be medically fit because most of the patients are from the elderly age group. Proper positioning of the patient on the post of the side of injury. The correct entry point. If we have made correct entry point within few minutes, our time is spared. If we are just hassling with the entry point, that is wasting our time a lot. Canal opening reamer to a proper distance up to the level of lesser trochanter at least. Canal reaming up to the optimum diameter so that nail snugly fits into the canal. Proper selection of nail, either it is a short nail or a long PFN, is to be used for this particular patient. Proper entry point to leg screw from the level of lesser trochanter going just adjacent to the calca. Okay, so that should be the inferior most area where we can put our this compression screw. Both screws in the neck should lie in the center of the neck in lateral view, overlapping to one another. Shadow should be overlapping. When guide wires in the neck are congruent, again there's a problem. Many times we are putting the guide wire for the screw. Once we start and the guide wire goes into the either congruent position or they may be deviating one away from the other. What to do in that condition? You do reaming up to the level where you can easily do, but do not go forcibly. Otherwise, your guide wire may be cut at the place of the hitting where it is hitting. So what to do? Pass the leg screw first in the right plane. Then while passing the derotation screw, withdraw the guide wire to some extent back. And then screw the derotation screw without the guide wire. It will be, because it is much more harder, it will take its own path. Otherwise, our this guide wire will not allow this screw to go ahead. So we will have to withdraw the guide wire to some extent, and then without the guide wire, you can advance the screw. And another important thing, derotation screw should be 15 mm lesser in the length than the leg screw. Our inferior one is the leg screw or the compression screw. The upper one or superior one is the derotation screw, just to check the rotational movements at the fracture site. Thank you very much for this patient hearing to me. Thank you, sir.
Thank you, Dr. Kaushik, for elaborate point-wise elaboration of the technique. But then also, I think there might be many questions in the mind of panelists, and the entry point about the subtrochanteric and the intertrochanteric is there. So it is open to discussion, and I would like the panelists to ask if any question is there in their mind.
Yeah, Kaushik.
Yes, sir.
Yeah, I think nice talk. Really. I just want to ask you one thing. I mean, you covered lots of points which are very salient and I think very well done. A couple of things I wanted to ask was that as regard to the opposite, you said you must be careful about your varus and valgus, you say.
Yes.
Suppose if you are getting a good reduction and you feel it's a varus, the best thing to do is screen the opposite hip.
Yes.
Or it's a valgus, so don't get uneasy about, oh, my reduction, my center of the tip has to be in the center. Because a lot of people have varus hips, a lot of people have valgus hips.
Yes,
so that's so one thing is you won't be wasting your time on thinking anything else. What happens now in a patient who has got a history of malignancy? What do you tend to do those patients? Elderly patient, see a breast, see a prostate man. What would you do to those patients?
If the patient is having a CA breast or something like that, any malignancy, it's a pathological fracture. Can we avoid reaming at all? Because there are chances of excessive bleeding from the malignant tissue. So we don't ream that cavity. We just try to pass the nail if easily it can pass. Reaming is, I think it will bleed a lot if we are doing reaming into the malignant tissue. So we should avoid reaming in that condition. Rather, even a smaller nail may be put in so that patient's nursing care may be done, or the chemotherapy or etc. Treatment for the carcinoma may be done. So reaming should be avoided in such cases.
I mean, in this scenario you're mentioning, sir, I'm saying the patient doesn't have a pathological fracture. It's a patient with a history of prostate cancer. It's a patient with a history of breast cancer. It's you want to do a DHS or a long nail. What would you prefer doing it in a patient? It's a non-pathological history of CA prostate or history of malignancy.
You mean to say that it's a traumatic fracture?
Yeah, traumatic, yeah.
And simple like that, like any other patient, you can treat him.
So we tend to do slightly different for a reason. Even if this patient is suitable for a DHS, okay, I'll tend to put a long nail for a reason. I'm covering his secondaries. So one operation, one time, job done. That because he may have a secondary deposit sometime later, isn't it? So in that case, you've already spanned the femur and the job is done then.
Yes, definitely. But if the patient is a known case of any malignancy, definitely we are going to put the nail at least for future. We don't know how much life is still left. So we have to definitely, if there are definitely secondaries in the bone, we have to, we need not to bother for that. We just want to fix the fracture. The rest of the job will be. Otherwise,
and also in patient, if they have got a total knee replacement distally,
yes,
and you're having to think about doing a long gamma nail, or sorry, long PFN. I don't have experience with PFN. I do gamma nail actually. So, and we don't do ever short gamma nail is available by Stryker. We don't do it because it got a bad name causing stress fracture. So either we do DHSs or long nails. Okay. So a patient who has got a total knee replacement, how do you do it, and what is the length of the nail? How do you evaluate?
I think we can go for the short nail also without any problem. If it is a subtrochanteric fracture, then we prefer the long nail. Otherwise, if it is an intertrochanteric fracture, the short nail is good enough.
Yeah, that's fair enough. But with the long one, the only thing, the tip of the nail, if they got a knee replacement, you might have to go slightly more distal to avoid the stress fracture.
Yes.
So that's one has to keep in mind. But yeah, I think you've covered most of the thing. Well done.
One point about the entry point, Dr. Kaushik. I would like to stress for those because you told this for the PFN which has 2 screws in neck. For those who use PFN A2, for example, I do PFN A2 only. The entry point, in fact, should be not medial to the tip of trochanter. It should be a little lateral to the tip of greater trochanter, because the PFN A2 has a 5-degree medial to lateral angulation, which probably these Indian nails or the one with 2 screws don't have. So those guys who are listening for PFN A2, they need to be on an entry point which is slightly lateral to the tip of the greater trochanter.
Yes.
Another point I wanted to know, Dr. Kaushik.
Sir.
You told that a greater trochanter should be at the level of the center of the head. Very right.
Yes, sir. It is the tip of the GT. Tip.
Yeah, tip of the GT. But then I probably heard that in varus, from my point of view, in a varus reduction, it should go up, greater trochanter.
Yes, sir. I had mentioned it.
That is mentioned.
Yeah, he has mentioned the same.
Yes, sir.
Okay. Fine. I probably missed that. Yeah, thank you.
Yeah. And
Thanks.
Dr.
Well
Kaushik,
Yes,
Kaushik, it's a very, very nice presentation. I must congratulate you for giving us all the very, very small tips. Can I share something with you?
Yes, sir. Yes, sir. Why not?
Yeah. One is the very, very debatable point is the point of entry.
Yes, sir.
So somebody says tip of GT, somebody says medial to the tip of GT, somebody says 50% in the neck, 50% in the GT, somebody says in the piriformis fossa. So my mandate is this, and my experience. So for the subtrochanteric fractures or the proximal shaft fractures, the tip of the piriformis fossa is the point of entry. But if you are planning for the intertrochanteric fracture and you are getting 2 lateral, say 4 millimeter lateral, 5 millimeter lateral, and directly, so we can go with the flexible wire to the shaft. But when we insert the neck, because the lower part of the neck, either it's PFN, long PFN, short PFN, that hurts the medial side of the cortex. So always it is better to be inside the neck. 50% of the neck, the hole should be in the 50% in the neck and the 50% at the base of the GT. As soon as you go out and you draw on the skygram, then you will be very oblique while getting the entry to the canal. And always it creates a problem in reduction. Number 2, if there is a shattered greater trochanter,
yes, sir,
and you are not able to appreciate where is the piriformis fossa, where is the tip of, then where you get the entry point?
Sir, many times we have to go even through the fracture site. But what we
fracture site,
even through the fracture site, if we enter, keep our lateral cortex pushed when we are on the proximal part of the canal. Make sufficient space for the accommodation of the proximal part of the nail. So that sort of trick, we just push it inward so that some part of this cortex is also, some part of the canal is also reaped. In that condition, our nail will be accommodated and both the fragments will be come together when we are using this compression screw. But another thing, many times, when difficult reduction, what we do, insert Stillman pin or Shan's pin into the anterolateral part of this proximal fragment, so that we can manipulate the abduction, flexion, and everything can be manipulated with the help of this pin. It also helps a lot. But really, two things are very difficult. First thing, putting the guide wire into the proper position. It should be neither anterior nor posterior. And secondly, achieving the anatomical reduction or near anatomical reduction, because we see AP view is very good, but when for the lateral view, we see fragment is lying. So that
reduction is the key success. If the reduction is not perfect, we will end to the implant failure. And one thing is more I want to either share or want to ask you, the positioning of the Siam. Because if you see in the AP view, the neck is anteverted.
Yes, sir.
So do you take care during your AP view regarding this anteversion? Do you
Yes,
make
sir.
any changes in the hip position or in the position of the Siam?
We are keeping the our limb somewhat internally rotated.
Yeah.
After the reduction, we keep it rotated, but when we have fixed the proximal part, our both have passed, then we correct the rotation. Before the putting the distal screws, we correct the rotation into the normal. Then we fix the distal screws.
And my third suggestion is this: as I agree with Dr. Sethi, seeing the biomechanics of the intramedullary implants, the long nail is always more biomechanically stable rather than the short nail.
Yes, sir.
And that gives the leverage, that gives the good relative stability. I agree with him and I prefer the same for that.
Yes, sir.
Thank you for a very nice presentation. Very, very nice presentation.
Thank you.
Can I
Dr.
make one
Kaushik?
comment, sir? Sir, can I make one comment, sir? Dr. Kaushik, really a nice presentation, very little and very, very small, important points you mentioned.
Thank you.
I like to open a new, let's say, a controversy of the distal locking. My take on distal locking is slightly different, but usually people do, or what you have explained, that in the intertrochanteric fracture, I'm not talking of subtrochanteric fracture. Subtrochanteric always distal lock. In intertrochanteric fracture, when the compression is between the neck and the trochanteric part, that is the distal, I do not see much use of distal locking. On the other hand, in many cases, when there is a static, especially locking, or both the screws are locked in the distal locking part in the intertrochanteric fracture, then there are chances of backing off screw too much, or Z effect is more, simply because this particular distal part is too rigid. We do not actually need much fixation of the distal locking bolt. Only PFN with the longer nail, as long, say 25 centimeter, if you are using of the intertrochanteric fracture, is good enough. And usually I don't lock any intertrochanteric fracture. This inspiration I gathered by the discussion with Professor Halder. Dr. Sethi, I think he is there, he must be knowing that Professor Halder was told that when he discovered his nail, Halder nail, Halifax nail, then he did not have any holes for the distal locking. Later on, these pharma people or instrument people made for the distal locking through making jig and all that.
I think I'll answer your question. What has happened? That's true. I've worked with Mr. Halder. He's retired.
Yeah, Dr. Sethi must be working with this.
And the nail was designed in this hospital where I'm working. Started getting the nail done in. He's a great man. So let me tell you, what he was mentioning was for the short gamma nail. Short gamma nail, we never used to lock for a reason. We were getting a lot of stress fractures at the tip. With the long gamma nail, we will always lock.
Okay.
For the short gamma nail, and because that was the reason, but he didn't want to have a screw, but this was made by How Medica. The nail gamma was not given by him. The gamma was given by German because it looks like gamma. He wanted the name in a different way. Anyway, so but the short gamma, we never used to distal lock it. However, with the gamma nail, there was a provision of locking holes, but we never locked it for a reason that it used to have a lot of stress fracture at the tip.
So the same thing.
So,
Dr.
Neeraj,
Yes,
biomechanics says if you don't lock the distal in long nail, then it will be just like you are not holding the long handle of the hand pump, and that definitely gives an stress over there. So for the long nails, distal locking should be done, and if we don't do in the short nails, that, as Dr. Sethi has said, that leads to the peri-implant fractures, tip fractures. That is the reason. If we lock it also, then we can reduce the fracture rate. So according to the biomechanics, fixation of the distal end, even only by the one fixation point, it's must, what I think.
I think you're right. I've seen people, one of our consultants used to lock distally, and he had troubles because it looks good on day one. After 3 days, they're all in external rotated. We have to bring the man to distally lock it. What you can do is, if you're happy with the fixation, just do one distal locking.
Yeah,
out of the two holes, do one.
Yeah.
If you're doing a subtroch, you do two. I still do two for even intertroch, but that's my choice. But if you do one, nobody can criticize you. It is only about the rotation. And I think one should distally lock it. The canal is wider as well. And I think we should. And also, I think Kaushik was rightly said, you should never hammer the nail as far as possible. And see on the lateral view. If you feel on the lateral view, your tip of the nail is still in the center, why your nail is not going? The best thing is take the nail out, ream bit more, because every femur is different. The nail is a fixed sort of a curve. So maybe if you've done 12.5 for 11 nail, go to the 13 and then put a nail.
Yes.
So don't hammer it.
Sorry.
Yeah.
So Dr. Kaushik, there is one more query about this, and that's a very important issue. As the patient is getting elder, and in the geriatric patient, the anterior curvature of the femur.
Definitely.
For the long nails, we have encountered a lot of times the nail get to stuck at the curvature point. That's at the junction of the proximal and the middle one thigh. So how do you manage it?
Well, I think
what are your protocol for this?
That condition should not insist upon the long nail. Then we should be satisfied with the shorter nail as long as we can go. Beyond that, it's detrimental. Because if we are creating another fracture, then it's a trouble to the patient and also for the doctor. So we should opt for the shorter nail. Then we can go for the few weeks bed rest for the patient, or just partial weight bearing or non-weight bearing. He can walk with the walker. But in that condition, we can never try for the longer nail. It's going to be detrimental.
So I have not done, but mentioned in the literature, then if you just consider that anterior curvature of the femur, you can also bend the nail. You can increase the curvature or order to the company with the increased curvature. That is mentioned in the literature, but I have never done it. I've never done it.
If we are more curvature to the nail, it would be very difficult to negotiate into
That's true. That's true. That's true.
It won't be
That's true. That's true.
Because we are not putting it from the lateral side.
That's true. That's true. That's true. That's true.
One question to Dr. Sethi. Dr. Sethi, as I understand, you said that you routinely don't lock proximal femoral nails, short from proximal femoral nails.
No.
Because I always lock short proximal femoral nails with a dynamic in dynamic mode. I usually use Synthes PFNA2 because locking, as you said, prevents rotation, and the most important, it prevents the toggling of the nail, which is very troublesome. So dynamic locking prevents both these things. So I always do that.
No, I agree with you. I'm not saying that's why we don't use short nails at all. Because of the fear because maybe PFN is slightly different than the gamma. I'm talking about the gamma nail. Gamma nail had a big problem of stress fracture. And if you see the history of gamma nail was very much recognized, and suddenly it dipped down badly.
Yeah.
Twice. The two reasons was the company made a distal locking hole, and they started locking everybody. Thirdly, it was not mentioned in their literature not to hammer it. They used to hammer it, used to blow out on the top. The
And it
gamma
was a static distal hole? Or, dynamic?
initially it was only static in the short gammas, So what has happened? Gamma has gone through gamma 1, gamma 2, gamma 3. This is a spiker one, which is slightly chain model. And the main thing was, because I don't have experience with PFN, maybe PFN is slightly made differently. But whenever we used to do a short gamma, in case, we never used to lock it distally for a reason of worry about periprosthetic fracture. So we normally made plan, we'll do all either DHS or long gammas. And that's what we do now. We don't have any short gamma nail on our shelf anymore.
Okay.
I never prefer the short nails. I always prefer the long nails because whatever the biomechanics says, that prefers the long nails. That gives the better relative stability.
Because nowadays you see what of these patients are living longer, and with a long short nail, what happens is, suppose now they have a shaft of femur fracture. You're neither here, neither there. So if you expand it distally, then it's good. It's better to use a DHS than short gamma for a reason. Suppose a patient with a DHS had a DHS done. Now this patient has got a distal femur fracture. So what you can do is, rather than taking the implant out from the top, you go from the retrograde nail and take the 2 screws of the DHS out from the bottom and lock it anterior posterior. So there's no stress fracture in between the 2 implants as well.
Yeah.
So
point taken.
Yeah, Dr. Kaushik.
Yes, sir.
Will you like tell us something about if the lateral wall is completely shattered?
Yes, sir.
So the nailing is same, everything is. Will you like to add something?
So still we do it without any trouble. We just put the bone grafts if it is feasible. Otherwise, we are doing it the same way. There's no problem, even if the lateral cortex is shattered. But what to do? We just ask the patient to do rest for a few weeks, so that the fracture union starts. Then only partial weight bearing may start. I would like to vouch that since after the introduction of the PFN, we have stopped altogether doing the DHS in the this intertrochanteric fracture. Even we are not able to show the technique of DHS to our students, PG students. Every intertrochanteric area fracture we are fixing with the PFN.
And
so the
second,
students will not be able to learn the DHS. That will be a shortcoming, Doctor.
I think
you are in a teaching institute.
That's the criteria. That's the stable and unstable. If it is a stable fracture, we should go for the DHS. And if there is any doubt about the stability, then prefer the PFN. So A1, A2, A3, B1. That's the DHS. And B2, B3, C1, C2, C3. And reverse oblique, go for straightforward PFN. I think everybody will accept this mandate.
Can I ask one thing, I mean, what do you do post-operatively with all these fractures, intertroch or subtroch?
Fractures fixed with the PFN. We start with this toe touch gate on the very next day.
Now, I want to ask one thing. A lady of 90 years of age, how will she do toe touch?
No, that condition we have to refrain. Because
I totally agree with you, and that's what it should be done. And we have problems here.
Yes.
We have problem because she lives on her own. We all our fractured DHS. There is my instruction is full weight bearing day 1. I'm not saying it's right. In India, don't do it because the social structure is so. There's a grandmother, they've got a daughter-in-law. These are bone sutures. It will take time. The load sharing and load bearing devices are different. But we sometimes have problem of early failure for one big reason. We have no choice then to fully weight bear. So if they don't partially weight bear, they don't go home. We fully weight bear and we have problem. But I think one should, but in the Western world, you will find they don't write partial weight bearing. Partial weight bearing is only at the moment is only for cannulated use. Otherwise, full weight bearing, which may not be a very good answer, but that's how we are.
But sir, we have to assess the patient individually because there are many patients. If you give 10% liberty, they take 90%.
No, I agree.
There are patients whom you give 90% liberty. They are afraid of taking the liberty.
No, I would do everything the same. If I was in operating, I will never let them fully, because the stakes lie high. Because if the fracture fails, I'm going to be criticized, and the people are going to be. Before I finish, how do you position for the long nail? In adduction or abduction?
In adduction, sir.
Adduction, all of them.
Sometimes if fracture is not coming in the adduction, that is, you can say displacing, what we do, we pass 2 K wires, thick K wires in the anterior cortex from distal to the proximal fragment. We make it stabilized, then we do the adduction. Because without doing adduction, we are not able to pass the nail and guide wire, etc.
I think
Dr.
Dr. Sethi, I think that's a good way that you do the reduction in neutral position or in the abduction, then fix with the anterior K wires, then making the entry point and for making the nailing, you adducted so that you can get a good space. In neutral position and abduction, always your instrument shall be hurting on the body of and the abdomen and at the chest. So you need a straight line to put the nail and as well as your reamers, whatever reamer you want to do. So I think that's a very good idea.
And sir, I would like to add 1 or 2 more points for compensating the 15 degree of anterior rotation of the neck. You can slide the table 15 degree, tilt the table 15 degree. One thing, you fix the patient on the opposite ischium so that you can get more way to adapt the patient, adapt the limb. And fixing with the 2 K wires anteriorly is always a good suggestion. Always. Even if the fracture is not much displaced, then also it makes your job easy.
Yes.
And one more point about the hammering of the nail.
Yes.
There is a difference between the hand-driven nails and hammering. The literature says the chances of fat embolism are much more higher after the hammering because the intramedullary pressure increases. So even in the simpler nail, we should go by the hand-driven nails.
But sir, in the last of the journey, sometimes it is so tight that without hammering the last 2 or 3 strokes, it is very difficult.
I think should be avoided. I think should be avoided because hammering is not under your control and hand driven is under your control, hand control.
So you don't have the hammer when you are doing a PFN?
No, I do not prefer hammer. Or if at all I have to do, it should be very, very gentle as paying respect to a lady. It should be as respectful.
The only thing is, what you can do is, as I said, because the curve is different, the nail is different, just slightly more. Suppose for you will do 12.5, 11 nail, you do 12.5, because the proximal, you've already over-reamed it, that will accommodate. It's mainly to have any fracture which progresses, go for another 0.5 more and then put the nail, and you will be pleasantly surprised. One, as Kaushik was saying, for long nail, make sure not hitting the anterior cortex, but if it is hitting the anterior cortex, too late. You can't do anything now. So other thing is, when you feel that one other trick is, if suppose you're putting, as Kaushik said, your guide wire is bent and it is not following the path where you would like to, what you can do is you start reaming with the guide wire slightly proximal.
Yes.
Because you can even put a reamer and then put your guide wire, So because the reamer is bigger, the canal is broader, the wire is smaller. So it goes the path of least resistance. So you can gradually progress. But these are few tricks. It may not work, but hammering the nail is not good. If your lateral view showing anterior cortex is still okay, Y nail is not going, just ream 0.5 more. And you make your life easy.
Because Dr. Sethi, one thing is very important to see. The canal is curved. And angulation, we don't see that it's 5 degree, 10 degree or 12 degree. So the width of the nail is more required rather than for the straight canal. If you are putting a pipe in the pipe and the pipe is curved, you require more.
Yeah, that's
Yeah.
true. That's true.
Yeah.
Dr. Kaushik,
Yes,
do
sir.
you prefer positive reduction or the neutral reduction?
I think it should not be only varus. Avoid varus at any cost. We have to avoid varus. If we are fixing it in the varus, we are fixing it not to unite. So valgus reduction is acceptable, but optimum reduction should be tried. But many times what happens actually when you are tightening this compression screw, some degree of reduction loss may be there. But don't stress upon it too much. If some degree of loss is there, no problem, it will unite. But it should not be in varus.
That's
Yeah.
true. One of my mandate is also there. If the screw size is more than 100, 105,
Yes.
then
Oh.
again check the reduction.
Yes.
I can be in varus.
Yes.
So this is my
Very-
tip. And on the operatively on the reduction and post and doing the complete surgery, you can decide the fate of the surgery. This will be the fate.
Yes.
So there is a score of 6 points: the angle of the nail, zone of the nail, tip zone, the bone condition, and point of entry. So they all decides, and there is a marking for these all things that decides the average marking, above marking, or the below marking. That decides peroperatively the fate of the surgery.
And the one more thing is, we have a paper which was presented here in not recent, it's been a few years. When we do a DHS, if it's a left-sided DHS, we always put a KR on the top, not for the right-sided. Because when you do the triple reamer, with the way we internally rotate the femur, isn't it, for reduction? Imagine when you're putting a triple reamer and trying to put the nail in, it loses the reduction. Because in the left side, imagine right-handed person rotates the hand right, and when you have tried to reduce it, you have reduced the clockwise or anti-clockwise. So the left-sided, if you're doing a DHS, put a D rotation on the top, take the wire out, and on the right side, you don't need to worry.
Okay.
It's
Very good
interesting.
tip. Dr. said
And
it's
you have a
interesting tip. It's a logic point. It's interesting point, really.
So I think everything has been covered very beautifully and in a very illustrative manner. If anything is not left, I think we all have become a little wiser, and what we know, we have revised it beautifully. So we will be having a short conversation after the meeting is ended from the audience. I thank the audience and the panelists and the speakers for such a nice discussion on
Thank
both
you,
the
sir.
topics.
Thank you, sir. Thank you.
Thank you.
Thank you.
And I am very much thankful to the Ortho TV, Dr. Bijlani and Dr. Ashok Shyam for giving us this opportunity. And I thank on behalf of the Uttaranchal Orthopaedic Association to all of you. And our next symposium will be a pediatric orthopedic symposium on 25th of August at the same time. Now I would request Poonam to get us off the air so that we can have some other discussion.